Dear colleagues, chairs, good afternoon. My task today would be to discuss what's new in the management of patients with atrial fibrillation, and these are my declaration of interest that I'm not going to go into details with. It is very important to realize that integrated holistic management of atrial fibrillation is essential to improvement in patient outcomes. And this has been nicely summarized in a central figure of the 2020 ESC-AF guidelines with an acronym CC2ABC. CC standing for confirmed atrial fibrillation before start of treatment, then comprehensively characterize atrial fibrillation by assessing stroke risk, severity of symptoms, severity of AF burden, and then severity of substrate for atrial fibrillation. And these components are going to be addressed in details in the next presentations. So let's proceed with treat atrial fibrillation along the ABC patient pathway. A stands for avoid stroke, using most commonly oral anticoagulant therapy. B stands for better symptom control, and C for identification of comorbidities and cardiovascular risk factors that should be upon identification and addressed and optimally managed, and that is very important. As for avoiding stroke, the very first step would be to assess stroke risk. And for stroke risk assessment, 2020 ESC-AF guidelines recommend a risk factor-based approach using the CHA2DS2-VASc clinical stroke risk score to identify patients who are at truly low risk of stroke. So that's the first step, identify truly low risk patients. That is those with a CHA2DS2-VASc score of 0 if males or 1 if females. Why CHA2DS2-VASc score? Well, in general, when you think of clinical risk scores, any risk score is a simplification that is used in order to help decision-making in clinical practice. All clinical risk scores have a modest predictive value when it comes to identification of patients at high risk for some event. There are, of course, more complicated, more inclusive risk scores in general that include not only clinical risk factors, but also biomarkers. They do marginally improve on predictivity of a risk score. At least they improve statistical significance, but statistical significance is not the same as clinical relevance. And the score is expected to be user-friendly, and we need to balance stroke's predictivity against its practical application. Also, stroke and bleeding risk in atrial fibrillation are dynamic, and we will discuss that soon after this. So we saw why CHA2DS2-VASc. Why CHA2DS2-VASc and not CHA2DS2-VA, as recently has been proposed in some of the other guidelines. Well, CHA2DS2-VASc score includes female sex, which is not an independent stroke risk factor, but can be viewed as important stroke risk modifier because there is a significant interaction of female sex, of being a female, with the presence or one or more other stroke risk factors, including also age. So not including female sex in stroke risk assessment would facilitate missing a substantial proportion of patients with AF who would otherwise merit the consideration for oral anticoagulant therapy. Once stroke risk has been assessed, next step should be assessing the risk of bleeding. But there are several important remarks in this field. For bleeding risk assessment, the 2020 ESC-AF guidelines recommend a formal, structured, risk score-based bleeding risk assessment in order to identify non-modifiable bleeding risk factors as well as modifiable bleeding risk factors. First, to identify non-modifiable bleeding risk factors, because such patients should be flagged up for a more frequent, regular clinical follow-up, and then to identify modifiable bleeding risk factors so that such risk factors could be addressed and, if possible, completely corrected. For the purpose of a formal structured bleeding risk assessment using a formal risk score, 2020 ESC guidelines recommended the HAS-BLED score. However, it's very important to realize that the use of bleeding risk assessment should be appropriate and responsible, because bleeding risk assessment means that we need to address modifiable bleeding risk factors and also to flag up patients with non-modifiable bleeding risk factors for a more regular clinical follow-up. Importantly, high bleeding risk score value is not an excuse to withhold oral anticoagulant therapy or to deny oral anticoagulation to patients at increased risk of stroke. And this is not a matter of the bleeding risk score. It's educational and implementation issue. So to facilitate optimal use of bleeding risk assessment and optimal appreciation of that information, we have also introduced the recommendation that estimated bleeding risk in the absence of absolute contraindications to oral anticoagulant therapy should not in itself guide treatment decisions whether to use oral anticoagulant therapy or not for stroke prevention. Why formal structured bleeding risk assessment instead of just addressing modifiable bleeding risk factors as previously has been recommended in 2016 ESC guidelines? Well,
Tatjana, for some reason we lost the sound. Τι έγινε, κύριε? Hello?
Inferior strategy in comparison to a structured formal bleeding risk assessment. Why specifically HAS-BLED score? Well, according to a recent comprehensive systematic review conducted by Patient-Centered Outcome Research Institute, the HAS-BLED score had the best evidence to support prediction of bleeding risk. Importantly, both stroke and bleeding risks are highly dynamic, which means that low-risk patient may develop additional stroke risk factors soon after AF has been diagnosed and patient has been initially evaluated. And it's very important to keep that in mind, and that is why the new guidelines recommended regular stroke and bleeding risk assessment at periodic time intervals during a structured patient follow-up. Once stroke and bleeding risk had been assessed, then there is a recommendation class 1 that oral anticoagulant therapy should be used in patients with a CHEST score 2 or more if they are male, or 3 or more if they are female. And for those with a single non-sex related stroke risk factors, the use of oral anticoagulant therapy should be considered as well. Wherever patients are eligible to NOACs should be preferred over vitamin K antagonists because there are numerous advantages, whereas left atrial appendage occlusion or surgical occlusion or exclusion should be reserved, the former for patients with absolute contraindications to oral anticoagulant therapy, and the latter for patients undergoing some other cardiac surgery. The next pillar of the ABC pathway is B, for better symptom control. And just to briefly summarize the strategies, optimization or rate control is essential to all patients with atrial fibrillation. However, should the symptoms persist despite optimal rate control, or there is a deterioration in left ventricular function that could be attributed to tachyarrhythmia, or there is a strong patient preference, or there are factors favoring rhythm control, that is suggesting that a rhythm control strategy is feasible in a given patient, then rhythm control strategies should be considered, mainly to control symptoms, to improve symptom status, and to improve patients' quality of life. Simultaneously with the presentation of the 2020 ESC guidelines at the ESC Congress this year, the results of the long-awaited EAST-AF-NET4 trial have been reported as well. This trial compared the impact of a structured intervention with early aggressive rhythm control against usual care in patients with atrial fibrillation, and the trial showed 1.1% absolute risk reduction in a composite outcome of cardiovascular death, stroke, hospitalization for heart failure or acute coronary syndrome with early aggressive rhythm control. And that risk reduction has been mostly driven by the reduction in cardiovascular death and stroke rates. Interestingly, there was no difference in left ventricular function or patient symptoms and quality of life. And the investigators of this study concluded that there is finally a high quality evidence favoring rhythm control strategies in order to improve patients' outcomes. However, if you look at the design of the EAST-AF-NET4 study, you will see that there is a significant bias, because in the intervention arm, that is early rhythm control, only in that arm and not in usual care, there was an intense, regular, structured follow-up, because patients were requested to record patient-operated ECG tracing twice weekly, or even more frequently if they had the symptoms, and then to transmit that to study team, which provided feedback as needed. That was the difference between early rhythm control arm and usual care arm, whereas all patients were adequately anticoagulated and risk factors and comorbidities were properly managed. But this difference could significantly impact the overall trial findings, because, look, there was nearly 300,000 ECG transmissions in the intervention arm. Think of patients willing to regularly record their ECG twice weekly or even more frequently. Such patients would likely be more willing to be adherent to any other treatment, including oral anticoagulant therapy, lifestyle modifications, and so forth. And it has been clearly shown in post-hoc analysis of other randomized trials, and also in a prospective randomized trial, MAFA-2 trial, it has been clearly shown that a structured, intense follow-up and a structured integrated care significantly improve patients' outcomes in comparison to usual care for patients with atrial fibrillation. Therefore, what we can see from the EAST-AF-NET4 trial is that the trial elegantly showed that an early intervention with a structured follow-up and intense follow-up significantly reduced cardiovascular adverse events in patients with AF. But the role of early rhythm control in the observed findings remains unclear, because there was a biased intervention arm, and we still need more data before we could fully appreciate the role of early and aggressive rhythm control.
Tatjana,
finally,
excuse me, Tatjana, I'm sorry for interrupting, terribly sorry, but we have to speed up because we are running out of time.
Yeah.
I'm sorry.
The third and the most, and the last and not the least pillar is the comorbidities and cardiovascular risk factor management, which can predispose to AF in a dose-dependent manner, the worse the risk profile is, the greater is the risk for AF, but also can significantly influence the development of the substrate for AF and hence affect the success of rhythm control strategies as well as the patient's symptomatic status and quality of life. And the interventions and treatments aiming at correction of underlying comorbidities and conditions have been shown to improve rhythm control strategies, symptomatic status, and patient's quality of life. And that is why such interventions are recommended in all patients with atrial fibrillation. Finally, the holistic ABC pathway of integrated care has been shown to improve patients' outcomes in a dose-dependent manner, each component being equally important for patient outcomes. And integrated management also needs to be patient-centered with active patient involvement through education, continuous collaboration, shared decision-making, and so forth. And why do we need such a structured patient care pathway? Because patients with AF can present to different levels of a healthcare system, starting from GPs to non-cardiologists and so forth. And we need a simple care pathway that can improve patients' outcomes. And this is CC to ABC. Thank you.
Thank you very much. Thank you very much for being with us.